So good morning, everybody. I'm Dr. Tasso from University of Florence, and I present you the study performed at the University Hospital of Leuven in Belgium about the post-prostatectomy incontinence treatment with these male slings. These are my disclosure, and I have nothing to disclose. So the male slings presents as a very interesting option for treat the post-prostatectomy incontinence, but we know from literature that the evidence about comorbid patient is not so strong. So we aimed to analyze the results on these kind of patients, and knowing that most of them, many patients with comorbidities ask for a sling before instead of an artificial urinary sphincter. So after a detailed preoperative counseling, we offer an implantation of the slings also to comorbid patients when they were well motivated and wanted to avoid an artificial urinary sphincter. And you can see we implanted 216 slings since 2007 to 2018, which almost 60% were ideal candidates, while the others had a significant risk factor for sling failures. The baseline characteristics were the following. We defined the incontinence as mild when patients were using up to 2 pads per day, and severe when they were using 5 or more pads per day. The outcomes were, we used 3 outcomes to define the success: the totally dry for patients using no more pads after the slings, social continence for those using maximum 1 pads after the slings, and we defined the failure when the reduction of pads was inferior to 50% from baseline. You can see how 23.4% of our patients were severely incontinent. So I present the results as outcomes in different subgroups of patients. And I also present the multivariate analysis that individuated the risk factor for sling failures. The follow-up, median follow-up, reached 12 months in the whole category. The social continent status was reached by 91% of patients in the first semester, and in the longer follow-up, it reached more or less 80%. As you can see, the whole group was performing a little bit less, and the comorbid patients were also reaching a pretty good level of satisfaction of continence that reaches about 50% in the last follow-up term. The totally dry status, similarly to the social continence, was achieved by a larger percentage of patients in the ideal categories of patients, while the pelvic irradiation and the urethral stricture were significant factors for reduced outcomes after the slings. The high PVR was defined with strict criteria, so more than 200 milliliters or symptomatics after removal of the catheter, and we described 46 events after the removal of catheter, but almost all of them were solved spontaneously within 1 month after the removal of catheter. We performed 2 slings transections due to persistent PVR. As you can see, also the difference of slings influenced the outcomes, because the new model of slings allowed to reduce the loss of effect during the follow-up, and also offered better outcomes to irradiated patients. The results of the multivariate analysis individuated the most significant risk factor for the 3 outcomes, for the totally dry, for the social continence, and for the PVR, and you can see how on the social continent outcomes, the most influence was the pelvic irradiation with an hazard ratios that overpassed the 0.3. So in conclusion, we can say that the non-obstructive slings are safe and offer very satisfying results, especially in well-selected patients. Also, not ideal candidates can benefit from sling implantation after an adequate counseling, and the pelvic irradiation as well as urethral stricture should be considered as significant risk factor for failure. Thank you for your attention.
Questions from the audience?
Sanjay Sinha from Hyderabad, India. During the period of your study, did you offer artificial sphincters also to your patients, and how did you allocate patients to the
Sorry, did you offer?
During the period of study,
yeah?
did you also offer artificial sphincter to your patients?
Yes.
And then how did you choose which patients were included in this study?
Well, it was based on patient satisfaction or not. So firstly, we considered during the follow-up time, patients that were not really satisfied from the outcomes of the slings were counseled again. And if they were asking for a secondary treatment for continence, they
No, I
could
don't
have...
think I made myself clear. In the entry to this study, I mean, at the point when the patient came first,
Yes,
did you...
when they reached a second treatment, they were considered as a failure. So they were out of the... were considered a failure.
How long you wait to transact the sphincter when you have urinary retention?
It was about 6 months in the median for the two patients, because we inserted a suprapubic catheter in those two patients, and we waited for more or less 6 months.
You don't try to release the sphincter before cutting?
The sphincter...
Don't release the sling before cutting? Release.
Well, it was transected and not released. It was just a second intervention.
Tasso, nice paper. Daniel Moser from Brazil. My question is the same. Why did you include severe incontinence and irradiate patients in your protocol for slings?
Because first of all, we assumed, we considered the opinion of the patients, and when they were well motivated to maintain a physiological voiding physiology, we offered them a sling, and we counseled them before the intervention that the results might be less interesting than in another category of patients.
My name is Frank van Rijm, one of the co-authors of the study. First of all, this is not a prospective study, it's a retrospective analysis of what we did, so we did not include patients or exclude patients. Secondly, a lot of patients just do not want a sphincter in our practice. And so we have a discussion with them, and if they are willing to go for a sling, and we have explained the risk factors for failure, and they pay the sling on their own because it's not reimbursed, then we proceed to surgery, and this is just a reflection of our practice.
Thanks very much. I think that if we come back to presentation number 2 and look at the quality of this study, you will not be very happy, do you? On the other hand, this is real-life practice, and we have to consult our patients in the best way we can from our practice. So how do we solve this problem?
If I may, so this is a great illustration, actually, where, supposing I was going to do a sphincter for somebody and I was going to tell them you're going to have a 50% chance of being dry in 1 year, that sounds like a terrible result, right? If I was only getting it right half the time, I mean, that sucks. But for that one patient who accepts the risks, I'm considering here the patient post-radiation and whatever bad factors you may have, what is their other alternative? If they're sitting there with a horrible condition according to their point of view, and you tell them you have a 50-50 shot of being better, well, now all of a sudden the same stats, but the glass is maybe half full from their point of view. So it may be perfectly acceptable, so long as we have good data to be able to actually have this real discussion where we're not just making things up, telling our patients what our opinions are.
I fully agree, if I can make one more comment. And the other thing is that we, for example, we didn't see one single erosion, or I don't think we make any patient worse than they were in our cohort. I think that's a very important factor as well.
Thank you very much.